All right, this is one we can break up if once Jim's ready. So we're going to talk about biopsy, active surveillance, all the things that do not involve surgery. You're here to learn techniques, but it's not everyone is a candidate for surgery. So how do you make these decisions? Well, it's going to be in the context of the patient. So you have the patient on the right, obviously not a good surgical candidate, although she may think she is. And then you've got the patient on the left, who you might have seen before, the young mother, has a few kids. She's freaked out because of her 1 centimeter exophytic tumor that she's not going to be around for her kids. And I could talk to her about a biopsy, and it's just going to go in one ear and out the other. She wants that out like yesterday. So that you've got two extremes of patients in terms of their, where these two may be no-brainers, but what about those in-between patients, those patients with comorbidities, elderly, that may not be the best surgical candidate? So treatment algorithm for a renal mass, on the top you have your surgical options, your minimally invasive partial nephrectomy, increasing in invasiveness to open partial, lap radical, and open radical. But then on the bottom you have your more conservative options. So, if the patient isn't a good surgical candidate, doesn't have a long life expectancy, this is where active surveillance and biopsy come into play, and potentially ablation as well. So the case for active surveillance. So we're seeing more detection, a stage migration. We're seeing more elderly patients with renal masses. Interestingly, despite all this detection, we're not seeing a corresponding decline in cancer mortality rates. This begs the question, are we overdiagnosing and overtreating insignificant disease? Many of these masses are indolent, up to a quarter of them are benign, up to a quarter of these masses are indolent. So your best candidates are going to be those who are older with comorbidities, smaller tumors, minimal growth, those that are most likely going to outlive their cancer, just like we're seeing the trend now for prostate cancer. We ready?
No, we have 10 minutes.
10 minutes, all right. Also, if you do active surveillance, it doesn't burn a bridge. You can still, if the mass is growing, if the patient is getting more freaked out, you can always go back in later and still do definitive management. So this is a show my kids watch. I don't know if you've ever watched Mythbusters before. My kids love this show, and goes through different myths and busts them. So I wouldn't be totally, emphatic about all of these, but I think all the arguments against active surveillance do have, it's not as cut and dry as you might think. So the perception that kidney cancer always kills people, actually the mortality is stable despite increasing treatments. All cancer needs surgery. Most of these are either benign or indolent. That the risk of metastasis is high. Actually, good series long-term from Jewett's group, I'll show that metastatic rate on active surveillance is actually quite low, less than 1%. Now, there are caveats. Growth does not predict whether it's cancer. Benign tumors grow too. Also, these studies have short follow-up, selection bias, most are retrospective, and we really don't have models to predict which patients have Mets. So, what is our best evidence? This is a clinical trial from Michael Jewett's group, prospective phase 2 trial. And now these were patients who were elderly and infirm. So a trial only tells you what it's good for and what they studied. So in elderly and infirm patients, about half of which got a biopsy, the growth rate was very low, 0.13 centimeters per year. A third of them didn't grow at all. And they saw similar growth rates with the benign tumors and the cancerous tumors. So growth rate was not a distinguisher here. Some patients progressed more rapidly, less than 1% had metastatic disease, but the take-home message is that for a select group of elderly infirm patients, it's a reasonably safe option. So what you have to do here is strike a balance between the risk of the cancer and the risk of the competing comorbidities. So, what I would call the sniff test. There on the bottom here, I've referenced online risk calculators where you can plug in all this stuff and figure out their what's their likelihood of living 10 years. I don't usually feel like I need a fancy risk calculator. When that old lady who's 100 walks in the door, you know that it's a bad, you know, that it's not a good indication. You should use some clinical judgment in doing this, but it can also help give the patient an idea of their risk. So another show my kids watch, I don't know if you've seen that What Would You Do show, where they give different scenarios. So this is a real patient. What would you do? 78-year-old female, big tumor, central, pretty ugly, lots of comorbidities. Has chronic kidney disease, prior abdominal surgery, hernias, she's obese, isn't very mobile, but it's a pretty ugly tumor. So what are you going to do? Who wants to do a nephrectomy? Who wants to do a partial nephrectomy?
Come on.
Come on, it's a big tumor. It's a big tumor. This is almost 6 centimeters, right?
Come on.
All right. Who wants to do nothing? All right. So I wanted to do nothing too. All right. So what I thought at the time would be a great idea. So when I see this patient, I am looking for a way out, exit strategy. I do not want to operate on her. So my way out was to do a biopsy, thinking that if the biopsy's negative, I've dodged a bullet here. Renal mass biopsy, clear cell, Fermin 3. So now we've got a high-grade cancer. So now what are you going to do? You're stuck, right? I'm stuck. I got the diagnosis. All right, so I took her to the OR, but I took her with this patient, I need to get her off the table. So a long, drawn-out surgery. She does not have the reserve to tolerate a bleed, a urine leak, and prolonged, you know, she just can't take a hit. She's got to get off the table. So we talked about a nephrectomy. So we did a minimally invasive robotic nephrectomy, burned through it in 45 minutes, had her off the table. I did not, but that would have been a great idea.
I think that's a great point. That's a great point.
So the question was, did you do a renal scan? So that would have been a great thing to do. I didn't hear, but you know, what if the other kidney's atrophic? In her case, her drop in her GFR, she still was over. She ended up at a GFR still around 40 or above when we were done. So, but a renal scan would have made a lot of sense here as to whether you're going to do an imperative partial, like open on ice. So I do the nephrectomy, trying to get her off the table, and what happens? New onset AFib. She has to go. Our cardiologists want her anticoagulated. She bleeds, has a wound hematoma, that gets infected, we drain it, she goes to rehab. So when it's all said and now her GFR recovered up to, I think 38 was her final, and she didn't go on dialysis. But, you know, and I thought through all this, and I'm like, this wasn't a good outcome. This was the very thing I was trying to avoid. But when I asked her about it, she's like, I'm so glad you got a biopsy, because I would have felt horrible if I went through all this and it wasn't even cancer. So a biopsy, at least she felt that it was worth going through all that because she had a bad cancer. And now she's doing much better now. So the case for biopsy, it can get you out of intervention sometimes if it's benign or non-aggressive. It just helps you be more confident in your decisions. Most other cancers follow the algorithm that you know what you're treating ahead of time. So why is kidney different? And it's all these perceptions that it's unsafe and inaccurate. It's actually much safer and more accurate. So arguments against a biopsy: it's unsafe, it's not accurate, we already know it's cancer. There is evidence that this is not as bad as we thought. Now, there are caveats. A biopsy may be safe, but when it goes bad, it can really go bad. People can bleed to death from a biopsy. So if you get a patient that's dropping their hemoglobin after a biopsy, AV fistula, you can't just sit on it. You have to actually be ready to intervene, put them in an ICU, transfuse them. It's rare, but it can be bad. Biopsy's not accurate. It is very accurate, but not so for grade. It can tell you whether it's cancer or not, but not necessarily the grade of the cancer. And, if you already know it's cancer, well, it may not, what we talked about, the extremes, the biopsy may not change management in the super old and comorbidity, or the young patient who doesn't care what their biopsy shows, because what if it's a false negative? So if it's not going to change your management, there's no point in poking them. So another study by Jewett, renal mass biopsy, over 345 biopsies. Accuracy was pretty high, 81%, and complications were low, no major bleeding, no seeding. Really, seeding is almost a historical thing. We just don't see that. So in conclusion, it's safe with good diagnostic accuracy for cancer versus not cancer. But just because a biopsy is non-diagnostic does not mean it's negative. In fact, in their non-diagnostic cases, they did repeat biopsies, and 83% of those, they were able to make a diagnosis on repeat. So the suggestion here is to consider a repeat biopsy for some of those non-diagnostics. So safety, we discussed the seeding risk is low, complications are low. I'll go through this a little more quickly because it's in your syllabus. Accuracy is good, but limited for grade. This is a review article. The message here is just the trends as we get more and more experienced in the biopsies in the recent era. The biopsy failure rate and indeterminate biopsy rate go down. And the biopsy, this is a paper from the Hopkins group, basically where they looked at took multiple sections on pathology looking for grade heterogeneity, finding a significant amount of grade heterogeneity in these tumors. So that begs the question of sampling error on biopsy, that you're not necessarily going to hit the highest grade part of the tumor. Here's a missed biopsy. This was a patient of mine. So look at the tumor on the right, pretty small posterior, should be a chip shot, right, for the radiologist to go in there for that posterior tumor. So this is my pathology report. Benign renal cortex and medulla. See comment. All right, so then I'm looking at this with the patient in the room. So you have to kind of do some mental manipulation, right? Take the tumor on the right, flip the patient upside down, and then now imagine where that needle's coming in, right? So the needle's heading laterally. The needle should be heading medially. I mean, even the patient looked at this and was like, that's not even close to my tumor. And I'm like, yeah, you're right. They missed your tumor. So a biopsy is only as accurate as the person doing the biopsy. And if you don't have someone you trust, you're going to end up with this, a completely worthless, result, or worse, a false negative.
My patient would have asked if that's his pancreas, but anyway, no, I think you bring up a good point, and frankly, we're doing more biopsies. We are, and I wouldn't say we're doing them on every patient. We're probably doing them on less than 20% of patients, but we are doing more biopsies, and I don't know where this is going to land. It'd be interesting to know in the audience, are people seeing more biopsies done? Yes or no?
Yep.
So there's about one third.
Pendulum's definitely swinging.
So about 1/3 of the people in the room are seeing more biopsies done. I think it's an interesting topic where we'll see where it lands. I think the most important piece of data that you stated was that biopsy can tell us cancer or not cancer, but getting the grade of the cancer is notably problematic in multiple studies. So, if you biopsy and it's a Furman grade 2 or 1, I mean, it can have a 3 component which you're missing. And I don't want to, quote 10 papers right now, but there is literature on this, and that's been our experience when we look at our retrospective review of about 120 patients. Same thing, we only have about 50% concordance on grade. So, yes.
There's a question from online. What's the risk of tumor in the needle tract of the biopsy?
I would say negligible. Craig, what would you say?
Negligible. There are less than a handful reported in the last 20 years. And I think it's now because of using coaxial needles. You're just not getting the seeding. The seeding cases weren't kidney cancer. They were transitional cell cancer.
But, we would say negligible, but I would never, ever tell a patient it's 0.
Yeah,
okay?
that's true.
I would say negligible. Ashok, what do you think?
Yeah, I mean, the literature quote less than 1%. I mean, that series, what Craig presented. But in my opinion, why do you do the biopsy? I mean, I tell you other way around. So why not to follow these cases? Like the case which you showed 5.5 centimeter tumor. either you operate or don't operate. In my opinion, because if you do a recent, like MR scan, we do a infusion, I mean, recent MR, they very much, they can tell about the papillary tumor and to certain extent clear cell carcinoma. So biopsy for more than 4 centimeter size of the tumor is not really indicated in my opinion, because you make a fair judgment based on the imaging studies. Now, question to operate or not to operate, again, she is a 78 years old patient. She's a geriatric population. I would talk to more about the what is the fertility score, what is the life, what life score, how is she going to survive 5 years, 10 years, then talk about the surgery and also the Charlson comorbidity index. And for the small tumor, my thought is like, why not to follow the growth pattern, because the enough literature is available. If the growth is say 0.27 centimeter, the chances of metastasis this tumor is less than 1%. If 0.54 centimeter, less than 2%, and even 0.78 centimeter growth per year, the chances of metastasis is less than 3% or so. So in my opinion, personally, biopsy really not much indicated. I mean,
So I'll comment.
I agree with you, Ashok, on the data, but sometimes it's an emotional question.
That was what came up here. So this is a patient that's pushing me to the OR. She wants to go now. I don't want to go. So, and I'm trying to talk her into active surveillance. And she's like, no, I'm not sitting on this. I want to go. So this was a negotiation. I'm like, all right, let's compromise. How about we get a biopsy? And if the biopsy is negative, because what if this is an oncocytoma? So that was an emotional decision where I was hoping to get out of.
So I'm going to say something that my radiologist tells me. It'll be interesting to see what people in the room think of this. My radiologist says, hey, while I'm biopsying that tumor, do you want me to just put a needle in it and freeze it and ablate it?
I get asked that too.
So, and sometimes I say yes, and sometimes I say no.
And I'll show some data on that. Also, the comment, though, about the growth rate. I mean, Jewett's study did show no correlation with whether it's cancer or even metastasis. So you can, it's easy, at least for a patient, to look at it and say, all right, I'm going to pull the trigger if it grows 0.5 centimeter, but that doesn't necessarily correlate with their true risk of cancer. We have a question in the back, too.
I just had a couple of comments. I went to a center to do laparoscopic partial nephrectomy where they routinely biopsied every tumor that came through. Sure. And like my first 40 cases that I did, I was like, why is this so hard? And then I got them to stop biopsying everyone, and it got a lot easier afterwards. So
surgery was hard.
Yeah, it makes laparoscopic partial nephrectomy more difficult. I don't have a robot, but at the same time,
I would agree with you. I've had cases which were biopsied which were more challenging, but I had others where they
you can't even tell. So I think if it's really intrarenal, it's less noticeable. But if it's really exophytic, the whole fat gets blown. The other thing I was going to say is that the one time we do use biopsy where it can be helpful is in the grade differentiation for patients that are going into active surveillance. You're going to watch them all for growth rates anyway, but if you get a high grade small renal mass right off the bat, even though they're not that accurate, it's
pull them out.
But if they tell you that, then you know you're going to operate right away. So it can be useful.
So let me make some general comments. Number one, I don't believe there's a consensus guideline on the indication of biopsy.
Correct.
Right? So whether you biopsy or not, I'm going to say that I do believe you're within the standard of care either way. Number two, I do believe that you need to discuss it, though, and document that you offered the patient a biopsy. And I have in our EHR template that pros and cons of biopsy were discussed. And I would encourage you to have that as part of informed consent on treatment of a renal mass, because the presumption is malignancy, but it's never 100% if you haven't done a biopsy. So I would encourage you to document that in your EHR. And, I do believe you have to put it in that you documented that you offered a biopsy. In fact, I feel pretty strongly about that.
Something interesting too.
Cons, just like you discuss the pros and cons of observation or a radical nephrectomy, and I think it's no different than a prostatectomy. You've discussed the pros and cons of radiation and
you observation.
Offer it. But I think it's an important part of informed consent.
A lot of patients will decline. They'll be like, no, I just want it out. The people who will promote biopsy the most will quote figures like this at the bottom that biopsy had the potential to change management in up to 1/3 or even 40% of cases. And if you look at that, so some of this comes from U of M, just down the road from us, where they biopsy routinely. But if you actually look at the data, so the biopsy is not being performed uniformly. Did renal mass biopsy increase their use of active surveillance? Yes, by about 5%. Did it decrease the use of radical nephrectomy? Actually, no, it increased it. There's actually more nephrectomies. And those may be patients like mine, right? Where you do a biopsy, it's an aggressive cancer, you're doing the biopsy to get out of surgery, now you're committed, so you're taking the whole kidney out. So what is the goal? You want to reduce...
Well, hold on, Craig.
Yeah.
One question. What is your opinion on biopsying a cystic mass?
I think the non-diagnostic rate's going to be high. Then you get in this question of tumor spillage and spread. And
Ashok, what do you think?
Yeah, I mean, the yield is about 70% or so. If you see the data of the people who have done cryo ablation for the cystic masses, their yield is about 60% or so.
I mean, if you think about it, the most prone, the best candidate for a biopsy are these indeterminate cystic lesions, because we don't want to operate on those. Unfortunately, it's the worst case to get tissue. So, there are institutions which are biopsying cystic masses, just to let people know. So, again, evolving area, and nothing in the literature can give you any strict guidelines on that.
So kind of summary of a few things. It's unclear whether we are truly reducing morbidity. If you biopsy everybody to spare a surgery for a few, are you really decreasing morbidity? It does help identify cancer without an operation. It helps prevent the removal. It doesn't necessarily prevent the removal of all cancers or kidneys lacking cancer, but and it's not convincing whether we're reducing over-treatment. So I'll skip through this. These are the AUA guidelines, which essentially say, if it changes management, consider it. So the idea of putting it in your consent that you talked about it. EAU guidelines really don't even say that. They just say it's an option for patients going on surveillance or ablation. I think these are due for updating. It looks like we're about ready to go to Jim, so I will wrap up here. Nope. Keep
Jim,
going? All right.
Jim, just finish your omelet. We're okay. All right, buddy?
You want me to keep going for a few minutes? Okay, all right. So here's one thing that the active surveillance and biopsy help you get out of. We're going to talk about a lot of complications. Those are highlights usually of the meeting. Everybody airs their dirty laundry. If you're not operating, you're not dealing with this stuff. The paper here by Span et al. Was from our multi-institutional consortium group. So you're looking at postoperative complication rate of 14%. Most of those are Clavien 1 or 2. Postoperative bleed rate, 4 to 5%. Urine leak rate, 1 to 2%. So potentially these are things that you can get out of in the appropriate patient. So future directions is probably getting out of the biopsy business altogether and using molecular diagnostic imaging to be able to better determine which of these patients truly had cancer. An exciting study coming out of Hopkins is using sestamibi scan that can help identify oncocytoma. There's even talk about doing the office-based biopsy. This is a paper from Jamie Landman's group at UC Irvine. So I'm going to mention the cryoablation for the very reason that Sam brought up. So if you're going to send a patient for a biopsy, you're going to get a call saying, well, I'm sticking a needle in it anyway. Do you want me to ablate this thing? Well, so who are you going to ablate? Kind of the same patients you're going to consider for active surveillance. The elderly, higher surgical risk, refuses standard therapy, ideally a small tumor less than 3 centimeters, posterior away from critical structures. Now, this is a paper that just came out, food for thought from the Mayo Clinic. Never would have thought this would have come out from Mayo Clinic, but this is comparing partial nephrectomy to ablation and essentially showing, so I'll read this because it's small, partial nephrectomy and percutaneous ablation for small and localized renal masses are associated with similar rates of local recurrence. This was a long-term study. So now I'm not saying throw your robot away. I'm just saying that it is food for thought that there are patients in which ablation can be an option. So what about follow-up on these patients? So this is just pulled out of different guidelines, but essentially for your low-risk patients, most people are going to get imaging at least once a year for at least 3 years. The guidelines talk about using an ultrasound after 1 year after a radical as an option. For your higher risk surgeries, you're going to follow those patients out at least 5 years and more frequently, usually every 6 months. For ablation, CT scan at 3 and 6 months and annually times 5 years. These are not set in stone, and if you talk to 100 urologists, you're going to get different nuances of this. What about active surveillance? So guidelines suggest CT within 6 months, then annually, and considering a biopsy for those patients. What about we talked about Bosniak cyst. What about the cystic lesions, particularly the Bosniak 2F cyst? So the American College of Radiology suggests imaging at 6 and 12 months and annually for 5 years. It's a lot of imaging, especially since the majority of these patients don't have cancer. So we don't have good guidelines here, and this is something that I think we need more follow-up, more direction from our societies. What about following a positive surgical margins? So what are your options? You either watch it, cut it out, or ablate it. So most of these positive margins, especially the focal microscopic positive margins, do not necessarily indicate residual disease or predict local recurrence or progression. So European Urology Review a few years ago also said this: the majority of patients with positive surgical margins remain without disease recurrence, and surveillance is considered an appropriate strategy, very close monitoring. I would step up my monitoring plan for these patients. But for most of them, if you go in, the papers that have looked at salvage nephrectomies showed that the majority of these patients actually had no residual tumor. So I think you've got a safe window to watch it closely. So in conclusion, ideal management is going to vary with the patient. It's going to vary with their comorbidities, and it's going to require good clinical judgment. But active surveillance can be a safe option in the appropriate patient, older with comorbidities. Biopsy can be one thing to offer certain patients where it might change your management plan. And I'll end with that, and we'll go to the case. Thank you for your attention.